Hello, my name is Dr. Christopher Sweeney. I'm a medical oncologist at Dana-Farber Cancer Institute. With regards to your question regarding what defines castration-resistant prostate cancer, the easiest way to think about it is when a patient presents and they've been on hormonal therapy, also known as androgen deprivation therapy, and also known as testosterone suppression, whereby their testosterone is being suppressed to castrate levels. When a patient presents, the most common feature we see that suggests that their cancer is starting to grow despite a low testosterone is their PSA rises. And basically we describe a suppressed testosterone as being less than 50 nanograms per deciliter, and a rising PSA is rising from the lowest level that we've seen it with the suppressed testosterone. It's oftentimes can be a slow rise, and a rise from a level of 1 to 2 to 4 over a period of months, but it's telling us it's the beginning of some independence from the lowered testosterone. So the question is, what is an adequately suppressed testosterone and what's the optimal suppressed testosterone level? We actually don't know the answer. There is one scenario. If a patient's testosterone is not suppressed, we need to look into that if it's not less than 50. It could be because they've just got, their body makeup doesn't respond to the LH-RH therapies. So we would then talk about maybe doing a surgical removal of the testicles so that they're surgically castrated. And that is guaranteed, by and large, to get them to a very low testosterone level. Or you could try alternate agents. If one's not responding to leuprolide, maybe they'll respond to goserelin or degarolarix in that situation. There is no data that I'm aware of that would suggest a testosterone being less than 30 is better than a testosterone less than 50. But I think a rule of thumb is lower the better. To take a step back, studies comparing LH-RH agonists saying that they're a level less than 50 looks as good as a surgical castration would suggest that the benchmark of being less than 50 is the bare minimum. But the fact that we know that we have agents that decrease testosterone levels and androgens lower when their testosterone is less than 50 would tell us that the lower you go, the better it is. It's like the game Limbo. How low can you go? You're absolutely correct. It is a very variable amount of time from when we start lowering testosterone till a patient progresses. A very small number actually progress within the first 6 months. What we've learnt though is we can identify patients who are likely to progress over a longer period of time versus a shorter period of time. One feature that we presented in the charted studies and has been seen in other studies is that patients who have a higher volume of disease at presentation have a shorter time to progression. So patients who have, in the charted definition, 4 or more bony metastases and 1 beyond the pelvis or the vertebral bodies, or those who had liver metastases or lung metastases, had a shorter overall survival and shorter time to progression. The flip side to that is patients who have 1 or 2 bony metastases or some isolated lymph nodes with or without a couple of bony metastases lived a lot longer. So that's one feature, is just the extent of disease that they have when they start the hormones. The other thing that we've learned is that the lower your PSA goes on hormonal therapy, the longer the hormonal therapy will work. So it's anywhere, in all honesty, between 6 months and oftentimes more than 6 years, especially for the patients with low volume disease.